So if you run or you're thinking about running, but your knee hurts, this video is for you. If you've been told running will wear out your knees, or running causes damage to your joints, or running makes your cartilage thin, or you should stop before you cause permanent damage, then I want you to pause, because most knee pain in runners is not caused by structural damage from running. And that isn't just my opinion as an orthopaedic knee surgeon, it's supported by decades of research on population data, imaging studies, and long-term clinical outcomes. This video exists because fear to avoid running ruins more knees than running ever does. Fear leads to avoidance. Avoidance can lead to deconditioning, and deconditioning can lead to pain because you lose your muscle and tendon and bone strength. So this cycle is entirely preventable when people understand how pain and inflammation works. So my name's Dr Arj Imbuldeniya. I'm a consultant orthopaedic knee and hip surgeon based in London. I've treated thousands of patients over the last decade as a consultant and many more thousands as a surgeon and doctor in training. I'm in a really privileged position as a surgeon. I get to meet my patients and examine them. I get to interpret these scans. For some of my patients, they end up having surgery where I will look inside their knees or hips with either cameras or physically open the joint with open surgery. I'll then repair and treat their injuries or the cause of their pain. And I get to go back and look at the imaging and the scans again and see exactly how things looked in real life compared to the scans. I also get to see how these treatments have helped patients or not helped patients. And because of that, I've got very unique perspective on what actually helps patients in terms of pain or injury to tendon, bone, muscle, cartilage, ligament, and the joint as a whole. I also want to be really clear that I now try and practice what I preach as someone who's nearly 50 with 4 children, 2 of whom are very young. One's a newborn baby and one's a 2-year-old. It's really important to me now more than ever that I last as long as possible, that my joint span, so the number of years that my joints are healthy as well. So I'm really invested in this, and I don't really ask patients to do anything that I haven't tried myself or that I'm not trying to do myself each week. As an example, as someone who is relatively overweight and deconditioned and not a runner, I managed to run the London Marathon in 2024 as a novice runner, having not done much more than 5 kilometers in the past. Using the techniques that I'll share with you, I managed to train for that and do the entire marathon without any injury in the lead up to it. I did have some pains for sure, but I managed to treat them with the same advice I'm going to give you, and they went away, and I completed it without stopping, which is an achievement for me. Fairly slow time though, hopefully better in the next few years. I didn't really do anything extreme. I just used concepts that we'll talk about later in the video that include load progression and resistance training, recovery, which is really important, good sleep, low stress levels, and really good nutrition. So we'll cover all of that in the video. So let's deal with one of the biggest beliefs that my patients have, which isn't true, and that's that running damages knees. When researchers have looked at large groups of people or large cohorts of patients in studies, running has not been associated with a higher degree of knee osteoarthritis or knee wear and tear of the cartilage. In fact, a major systematic review in the American Journal of Sports Medicine showed that recreational runners had a lower risk of osteoarthritis in the knees than those that didn't run. So this was about 4% in those that ran and about 10% in those that didn't or were sedentary. So running itself isn't the problem, is how load is applied to your knees when you run and how your knee is equipped to deal with it. So when we talk about wear and tear, we're often talking about cartilage. Cartilage is a thin, slippery substance that acts as a cushion, and it's on the end of the bones. So on this knee model, this is a knee, the cartilage is the thin layer just covering the bone, is not very good at healing, and wear and tear or osteoarthritis normally means that the cartilage is getting cracked or has fissures, maybe that some bits are getting thin or worn down or coming off loose. Cartilage doesn't have a direct blood supply, so its main nutrition is derived through movement and fluid in the joint that gets more nourished as we move the joint. And it's been demonstrated in multiple biological studies that movement nourishes the joint. Progressive loading, where you're doing resistance training and getting your muscles and tendons to get stronger helps support the cartilage, but sudden overload or prolonged repetitive activity can increase forces in the joint and cause inflammation and increase sensitivity to pain. So cartilage isn't good at repairing, but it is adaptable, just as your entire body is. So I just want to talk about walking as well. So lots of my patients quite rightly will tell me that they do exercise, that they walk. The issue with walking is, in my opinion, walking is a normal activity and it's not necessarily an exercise. So we were made to walk, that's why we have two legs. But because of our sedentary lifestyles over the last sort of 30 to 40 years, we tend to spend more time sitting. So we're either sitting, maybe watching this video, in a car, driving to work, in the office, at work, and of course when we're in bed, we're in bed lying down. So for a large part of our day now, compared to our predecessors, our great-grandparents for instance, we're not moving as much. So walking itself isn't an exercise, it's just what we're meant to do. And I fully advocate walking, but it's not going to help get your legs strong or help get rid of the pain that you may be having in your knees. So I don't think walking is exercise, but it is good for you. It's good for your mental health. It's good to get out there and have fresh air. And certainly if you're doing challenging walks up and down hills and the countryside, it is really good for you, and it can help a bit with strength and your cardiovascular fitness or your heart and lung fitness, but it's not going to help your knee pain. It's also not going to make your knee pain worse or damage your knees either. The next thing I want to talk about is MRI scanning. So MRI scans are a really amazing tool that we can now use as medical practitioners to help patients. The scan is harmless, there's no radiation involved, it's just mainly magnets, so you have to be careful that there's no metal when you're going into an MRI scanner, and that the technician has checked you appropriately and done a proper questionnaire with you. But otherwise it's totally harmless. It mainly just has a cost burden, so it either costs you or it costs the government if you're being treated on the NHS in the UK, or it will cost your private insurer if you have insurance. But otherwise, very good images are obtained in 3 dimensions of your knee or your hip or whichever part of the body that you have scanned. Having said that though, it only shows structure. And because of that, it's very normal to have knee pain or hip pain and have a normal looking MRI. And that really can frustrate patients and often actually can confuse your doctor or your physio or whichever healthcare practitioner is looking after you. But having a normal MRI doesn't mean that you don't have pain. We know you have pain, and I certainly do when I see you, but it just means that the pain itself is not seen on the MRI because there isn't a structural abnormality. So we don't always have a significant tear of a tendon, or we don't always have lots of obvious inflammation in the knee or swollen tissues. So it is normal and expected sometimes that the scan can look normal, and that's very heartening. It just normally means that you don't often need surgery, which is a good thing. But remember, in an MRI scanner, you're lying flat, normally on your back, and you're not moving. So it's not a dynamic scan. It's often a fixed picture taken at a certain point in time when you may not even have much pain. So don't be too frustrated if it doesn't show anything. And your practitioner should really understand that and not just say there's nothing wrong because the scan's normal. And conversely, you can have injuries that we can see in an MRI scan, but they may not be causing you pain. So there was a fairly well-known study in a well-known journal called the New England Journal of Medicine. And when knees were scanned in many, many patients, up to 1/3 of patients who were in their 40s or older had meniscus tear that was not actually bothering them. It was an incidental finding, which means it was just picked up on the scan, but it wasn't bothering them. So for instance, I'm middle-aged now as well, so I may have a meniscus tear if I had a knee scan, which I haven't yet, and it may not be hurting me. And if that's the case, we don't need to treat it. So sometimes we get pain and we can't quite see a mechanical or structural cause in the scan, and other times we'll see structural abnormalities, but they're not causing us pain. So it's really important that we understand that, and your practitioner or whoever's looking after you also understands that and explains that to you. So why do you feel pain in your knee then? Where does it come from? So just to reiterate the point, cartilage has no pain nerves in it or no nerve supply, so it can't feel pain. But pain normally comes from the lining of the joint, called the synovial lining. It can also come from the bone just under the cartilage, which has nerve endings and can feel pressure if the cartilage is thin. It can come from connective tissue, which are other layers in your body like fascia. Fascia is a very important, thin, cling film-like layer that wraps around your muscles and sometimes isn't very stretchy and can get quite tight around your muscles. It's very strong tissue actually. So in surgery, we have to often cut it to get through past it to the deeper layers. but when we sew it up with stitch, it's very firm and strong, and that has nerve endings. And any of this other surrounding soft tissues like ligaments and tendons, which when they're stretched or injured or inflamed, can cause or can make you feel pain. So cartilage can indirectly cause pain because any abnormal damage to the cartilage where it's not smooth and it's roughened or there's loose bits triggers inflammation and a release of chemicals into the knee that will cause the synovial lining to be sensitive and make it feel pain. So indirectly roughened or loose bits of cartilage can make you cause pain, but directly if you've got a cartilage tear, and sometimes even a meniscus tear, you don't directly feel pain from that tear, unless in the meniscus, for instance, the tear is in a certain place near the edge of the meniscus. You can find out more about meniscus in one of my other videos. So if the tear is near the edge where there are some blood vessels and nerve endings, then that directly will cause you pain. But often the meniscus tear itself is away from the nerve fibers in the meniscus and it's indirectly causing you pain because there's a loose bit of tissue moving about and your knee doesn't like that. It doesn't want anything moving about independently because it triggers inflammation. So in this knee running masterclass, I'm going to explain what load actually means, why pain doesn't always equal damage, what runner's knee is, what the IT band is, and about meniscus tears, fascia is and why it hurts, why strength can protect your knees, why walking isn't enough, why sleep, stress and nutrition are absolutely key to you feeling less pain or getting rid of your pain, when surgery actually does really help and when you don't need surgery. So I won't rush anything. I'm going to try to keep it simple, but hopefully not too simple as well. So before we go on, a quick medical disclaimer. This video isn't personalized medical advice because unfortunately I'm not your doctor, but it is medical education. Every knee is different and you're all different people. So if you are having pain or you're suffering with an injury, do find your nearest specialist who is going to see you and help you. So what is pain? Well, pain is really a signal picked up by pain fibers called nociceptors. It's normally a chemical signal that makes you feel pain. And it doesn't mean that you have damage, but having damaged tissue can often trigger chemicals that make you feel pain. And pain normally comes from excessive load or inflammation, chemical irritation, fatigue, stress, or previous sensitization to pain where you're oversensitized to something that maybe wouldn't be so painful to someone else or even to you years ago. You suddenly feel more pain than you should. So these nociceptors or pain nerve receptors are designed to protect you and give you a warning. And as mentioned, cartilage has no pain receptors or no nociceptors. In the knee, the most painful or sensitive structures, as mentioned, are the other structures like the synovium, which is the inner skin or inner lining of the knee, the fat pad called Hoffer's fat pad at the front of the knee, which can get quite squashed when you bend your knee or do repetitive activities like running. It can get pinched a lot and then it gets quite irritated. The bone just under the cartilage, that's called subchondral bone. So you've got bone in the knee, you've got cartilage here. Just underneath, we call it subchondral. Chondral is the word or the medical word for cartilage. So sub is just below it, and that feels pain and pressure. So if you have osteoarthritis and no cartilage, too much force is going through your knee, you feel pain in the bone. These tissues are richly innervated with nerve fibers for a reason, because they're there to warn you that the load is too much or you're not able to handle the load and you need to do something differently so you can handle it. So pain or the nociceptors can be activated when you're running and you suddenly increase your miles and you keep increasing without maybe rest or without getting stronger. If you've got poor strength or you're not as strong as you should be, if you're fatiguing, if you're doing too much incline work going up hills when you maybe should do it more gradually, if your footwear is not appropriate or your running pattern is not appropriate, so the load is not balanced or shared enough through your legs. And this means you can get knee pain without an actual injury and often with a normal MRI scan. And when tissue is overloaded, some of the substances that are released that can cause pain are called prostaglandins, cytokines, bradykinin, and substance P. And I put these words out there just so you can understand roughly what they are, because sometimes doctors or scientists will use these words and it can be easy to get confused. And in simple terms, the same run or load that you were fine with last week suddenly hurts this week, your knee can't cope with it, and you're having these chemicals being produced and you're feeling. The more a pain receptor is activated, the more sensitive it gets. And this is called sensitization. So this is why knee pain can come on gradually, sometimes over weeks and months, why it can get worse with repeated runs, and why it often appears at predictable distances. So you know at 2 kilometers or at 5 kilometers it's going to come on, I'm sure, many of you can relate to. Nothing dramatic actually happened. It's just the system or your knees become more sensitive because the pain receptors become more sensitive. So we use the word inflammation a lot. What's inflammation? So inflammation isn't automatically bad. Often inflammation is a good thing, and it's what our body uses to treat injury or infection. It's essentially a normal biological response to stress, and it exists to protect tissue, to increase blood flow, to initiate repair of tissues. And having short-term inflammation is really healthy. So you don't really want any inflammation in your body. It's a bit like a central heating system. You want it off most of the time, especially in the summer, and then you want it on when you need it. So if you want to heal from an injury or fight an acute infection or viral illness, you don't want it on all the time. That's what's called chronic inflammation. And chronic inflammation can happen for many things, but in running it can happen if you're running too much, you're not resting enough, if the running distance or the speed is too high all the time, if you're not doing a strength training and your muscles are fatiguing and they're not strong enough. Also, if you're just tired because you're working too hard, you're not sleeping enough, and also if your nutrition is poor, so you're not getting enough good green vegetables, hydration, not enough fluid, and also just generally maybe too much ultra-processed foods, that can also trigger you to have more inflammation. And pain often fluctuates day to day, and sometimes you might have a run where you do get pain and maybe a week or two later you do a run and actually it's fine and you think you're fine, but then again the next week you sort of break down, after 2 or 3 kilometers. And that's really because you're dynamic, you're changing all the time, and so are your systems, so the inflammatory systems and the pain receptors, and sometimes they're very sensitive and sometimes they're not, and sometimes certain forces or loads in your knee will trigger pain, and sometimes your body will be able to handle them because your cartilage will be in a good state, or your muscles might be a bit stronger one week than the next. So these things change just like you change, because you're a human and you're alive. It's a bit like a volume knob. Pain receptors can be turned up and down depending on the time of day, how much stress you're having, all sorts of factors that we've touched on. And fatigue's really important, because if your muscles are fatiguing and they're not able to handle the endurance that you need for some of your longer runs, or even just the power to power up an incline, or to power and be at a certain pace or cadence, fatigue makes your body process pain signals differently, so you can feel pain more. And also it can affect how your joint holds itself together. So if you're very fatigued and your muscles are not working enough, the knee can become quite unstable when you're running, especially if you're running outdoors or on uneven ground. And that can mean you're more likely for side-to-side movement. That's abnormal. That can stress the cartilage and ligaments and tendons, and then you can sometimes get injuries because of fatigue. And that's why pain often appears later in a run, because you're more fatigued than at the beginning. So we talked about stress. It's really important that we all try and manage our stress. As a surgeon, I've had plenty of stress, but I've worked really hard over the last few years to try and get a slightly better work-life balance, so I can sleep better, I have less stress, and this in turn has really helped me, not only in terms of mental health, but also in terms of physical health. And it's really hard. We all have our own challenges. We have lots of stresses, I'm sure, at work, or if you're running your own business, or if you've got family, or if you've got issues with your family, or just the various life events that happen to us. But if you're able to find strategies to manage stress, for sure your pains will reduce. And that's in particular because stress hormones like cortisol will reduce, and your baseline inflammation will also reduce. And sleep is equally the same. It's quite linked to stress, because often if I'm feeling stressed or I'm nervous about something, I often find it difficult to sleep. But if you can get a good night's sleep, again, your inflammatory markers and the levels of proteins in the body that trigger pain receptors and inflammation will also reduce. So they're kind of linked, and they're both really important. We talked about MRI scans earlier, but just to reiterate, MRI scans show structure. They're super detailed, but they don't always show pain. And it's difficult for them to show that. They can just show a 3-dimensional picture of the inside of your knee and the layers, but they're not dynamic. And so they're really useful, but they need to be taken into context with the history, which is the story you tell me about why your knee is hurting or what your injury was. The examination, when I examine you, watch you walking, watch you doing some movements, examine your knee and see how tight or lax it is, where it might be hurting you. And then we do the scan, we put everything together, and then it's really easy to come up with a good diagnosis and explain to you why you're having pain and what we need to do about it. So to summarize, knee pain will happen if you increase load too quickly. So you increase your runs, or even in the gym, you increase your weights too quickly so your body can't adapt. if you have poor sleep, poor stress, poor nutrition, and if you have lots of inflammation in the body caused by all sorts of factors that raise inflammation. So what makes knee pain better? Kind of the opposite, I guess. So that would be having rest, working on hydration and nutrition, working on your stress levels, doing strength and resistance training, which is the most important thing you can do for knee pain, but doing it slowly. So I just go to the gym once a week. That's kind of all I can really set aside in a working week. I spend about 70 minutes or 60 to 70 minutes in the gym doing leg exercises, 3 sets of 6 to 8 reps of all the machines in the gym that kind of strengthen my leg muscles, whether they're hip muscles or thigh muscles or calf muscles. And then I'm out of that with the loads. I do them heavy enough that 6 to 8 is challenging. But you know, sometimes I've got an ache, especially in my left groin. So the adduction exercise to bring my legs together, I really go light on that because I don't want to injure the tendon on the inside of my groin. But I'm really confident with quadriceps exercises, which is the muscle at the front of my thigh. So I go a lot heavier on those, so I feel quite good. Equally, my hamstrings at the back of my thigh have always been a bit weak and tight, and that's just how I'm built. So I respect that and I work on those a little bit lighter to make sure that I don't injure them. But you know, every week I go, after a few weeks, the weights or the resistance that I can push goes up, it goes up. And sometimes I have a difficult day because I'm tired, I just don't feel like it. And I have a weaker day, so I just lighten the load slightly, but I still do it. And I think it's really, really important that you try and do the same and understand that your body changes and just be really patient. And getting to the gym and doing that session, even if it's not a great session, is better than not going at all. So now we're going to talk about some common issues or diagnoses that runners can get. So the first one is going to be the IT band or IT band friction syndrome or Hoffer's fat pad impingement. So they're all quite interchangeable to a degree. Runner's knee is really common and it's something you may have heard of. And it often means pain at the front of the knee when you associate it with lots of running. And that's because between the patella bone here at the front and the femur bone behind it, you get a lot of pressure when you run and you bend your knee and you land on a leg that's slightly flexed. The two bones squash against each other. The cartilage on the two bones gets pushed against each other. There's a lot of pressure. Normally, whatever you weigh, if you times that by 3.5, that's the pressure going through the small patella. You also get squashing of the soft tissues between the bones, like the synovial lining, the fat pad in particular as well. And you do get some stress on the cartilage and the bone below it. Often when you have an MRI scan, it doesn't show too much. It may show a bit of swelling or inflammation in the Hoffer's fat pad. It may show some inflammation on the outer part of the hip underneath that. So what about IT band? Well, IT band stands for iliotibial band. That's fascia, and that's a very thick structure on the side of your thigh, and it goes from your hip or your glute muscle all the way down to the side of your knee on the outside of your knee. So on this knee, it goes all the way down the outside of the knee. That's the fibular bone. So this is the outer side and this is the inner side. In medicine, the outer side is called the lateral side, just to confuse you even more. The inner side is the medial side. So the IT band is on that outer lateral side. This is a right knee that I've got up, and the band sticks to the outside of the knee and rubs, and it can rub. And then that rubbing can cause friction, and that can cause inflammation and pain. So if something gets rubbed on for too long, if you rub on your own, if you get your fingers and rub on the back of your hand, it's fine at the moment. But if you do that for about half an hour, it's going to really start hurting, isn't it? So that's friction. So to reduce the friction, you want the space between the IT band and the structures below to be increased. That can be by stretching the IT band. It is tissue that can stretch and contract to a degree, but it's not muscle. It's sort of firm tissue. So even if you stretch it, often it can kind of come back to baseline and hurt you again. It's a bit like cling film or cellophane that wraps around our muscles. And it's quite good at feeling pain because it's got nerve endings in it. So though foam rolling can help temporarily and there's no harm to doing it, often it's not the long-term fix because the pain comes back if you haven't changed the kind of mechanics of what you're doing or how you're training or how strong you are or what your posture's like or what your footwear's like. So ideally strength training is best, in particular the muscles at the top of the IT band, which is the tensor fascia lata and the gluteus medius muscle and the gluteus maximus muscle. Strengthening those muscles will help reduce the load that goes through the IT band and will reduce the stress that kind of irritates it or causes it to rub quite firmly on the structures on the side of your knee. like Hoffer's fat pad and the synovial lining. We'll quickly revisit meniscus tears, though I've got a fairly detailed talk on it that you can watch on my channel, but they're really common. They're the most common thing I see in my knee clinic. The pain from the meniscus tear doesn't always occur because of the meniscus tear, though sometimes at the beginning it is the tear that is felt, but later on the pain from the tear is not felt, but it's the irritation associated with it because the load going through the knee is too much. When the meniscus is torn, it's not able to also help share or dissipate the load, and the meniscus, which is this tissue inside the knee here, this rubbery C-shaped like piece of cartilage that helps the top bone, the femur, fit onto the tibia nicely, so they're kind of wedged onto each other. When it's torn, the force going through the knee isn't spread enough through the meniscus because some of it's torn, so the torn meniscus can't help dissipate load. More force is felt, and that aggravates the knee more. It aggravates the lining, it stimulates the nociceptors or the pain fibers, makes the knee swell up. You get all those chemicals like substance P coming into the knee, and then you feel pain and you don't want to run. So it's often not the tear itself, it's often the fact that the tear's there that irritates the knee. And as I said, when you've got loose pieces of cartilage or meniscus flopping around and the knee doesn't like it, it makes it get inflamed. Sometimes the meniscus does hurt if it's at the periphery or the edge of the meniscus where there are some pain fibers. For sure, then the tear itself can hurt you. And if we repair the tear, and as a surgeon, that can often mend the tear because the blood supply is quite good there and it can stop the pain. Sometimes when we remove part of the meniscus, people are really fearful of that. And for sure, it's not ideal to have some of your meniscus removed. But if it's torn and it's unreconstructible, so it doesn't have a good blood supply and it's causing your knee to hurt or even to catch or lock, when we take out the torn piece, that stimulus is gone and your knee doesn't hurt anymore. So having a bit of meniscus taken out, if it's done in the right context by the right person who's super experienced and doesn't damage your knee, it's got a great outcome. It can get you back to all activities. So it's really important to just get good, balanced advice and also to do your own research and make your own minds up about treatments. But meniscus surgery to either repair or remove torn meniscus can really help if non-surgical measures such as strength training, nutrition, less stress, better sleep can all help. Then if none of those are helping you, then surgery is the way forward. And the surgery is a small operation done through 2 small incisions at the front of the knee, occasionally 1 or 2 other incisions if it's a difficult meniscus repair. And the surgery normally only takes surgeons like me between 10 minutes and about 45 minutes to do under either a regional block like local anaesthetic or a general anaesthetic, and patients are generally home the same day, walking, putting weight on the knee afterwards with some crutches for comfort. If you have a meniscus repair surgery, it takes a long time to get back to running because it takes about 2 months for the meniscus to heal, and then you need another 2 or 3 months to get your fitness back before you're safe to run. If you have a meniscus tear where the piece is not viable or there's no blood supply to it and it's not something that can heal and we remove it, conversely, you can be back to running within about 4 weeks. So let's talk about strength. This is the most important treatment that you can prescribe yourself or that any of us can prescribe for you. It's better than stretching, and it's one of the most consistent findings now in orthopedic and sports and medicine research that strength training is what's going to help you preserve your joints for longer, and that I'm looking forward to for me. So biomechanical studies show that strength training reduces the force and the irritation going through the knee joint. Being strong reduces fatigue of muscle also and risk of injury. And being strong changes your pain biology. So it reduces how sensitive those pain fibers or the nociceptors are. And I can assure you that seeing hundreds of patients every week, I rarely see patients that do strength training. Most of my patients are either very active, but they do lots of running, or they play lots of football or other sports, but they don't normally do strength training. Or they're patients who are very sedentary and again aren't doing much gym work or strength training. And the most common thing most of my patients who have knee pain or knee injuries tell me is that I hate the gym. So for sure, essentially by getting to the gym and doing some strength training, but also getting some really good footwear. So I got some stability shoes from Hoka, and I'm not sponsored by them at all, but either Hoka or other equivalent really good running shoe manufacturers like Salomon, and there are lots of others now. Getting good footwear basically can also really help spread the load evenly. Managing your weight can really help. So I tried to lose weight at the time that I was struggling, but I did try, and the lighter you are when you run, obviously the better, and the stronger you are, the better for sure. And all those things worked in a way that my shin splints and my plantar fasciitis, which were quite bad at one point during my training, just totally went, and I was able to do the marathon with absolutely no pain. It was really hard, it was really, really difficult, but I didn't have any injury or pain through it. And again, doing the marathon was really interesting for me as a novice runner because I saw so many people breaking down, having injuries, not being able to finish. And a lot of these people were like really, really fit. They looked a lot fitter than I did for sure. And I think a lot of it is down to, or I'm convinced, and I know a lot of it is down to how you train, what your nutrition's like, and everything that we've talked about. So let's talk about knee surgery. When might you need knee surgery if you're running and you're in pain? For sure, it's most useful if you've got a structural abnormality. So if something is torn or loose in the knee, if you've got loose cartilage, big meniscus tear, if you've damaged a ligament like an ACL or an anterior cruciate ligament or an MCL, and you're still really struggling after non-surgical therapy. So if the knee feels very loose or the knee keeps getting stuck and it's persistent and we can see a structural problem, then surgery can really, really help. Surgery isn't there yet to kind of make the knee new again. We can certainly try and help it resistant against deteriorating more, and that might be if you're poorly aligned. Sometimes we can do operations to help straighten your knees more. We can help cartilage to be protected so it doesn't break down as quickly, because we can help with stability in the knee. But we're not very good yet at renewing a knee. So if your knee is getting fairly damaged or it's fairly old inside the knee, we still aren't able to kind of make the knee new again. Anything's possible, and technology, as you know, is just advancing really quickly, and that's why it's a great field to be in, and I love it because it's always changing. But for now, it's important that you understand that the changes you've got in your knee are kind of there, and the surgeries, all the injections that we offer, like PRP or platelet-rich plasma, are quite good at helping reduce the rate of deterioration in your knee as you age. But at the moment, we don't have anything that's very good or scientifically proven to renew your knees. Though again, there are interesting technologies that have been out there and are evolving, like stem cell treatments, which again are still very unproven. But watch this space as the years go on. If there's anything new, I'm going to be letting you know about it. So let's wrap up with longevity. And what is longevity or ortholongevity? It's not really about eliminating pain forever, because that's not realistic, but it's about reducing it or keeping it away for as long as possible and building capacity in your knee that you and your body can adapt over time, and that progressively loading and exposing your body and your knee to very slight. So to summarize, running doesn't damage your knees. Poor load management can. Walking is really healthy, but it's not enough. Strength absolutely protects your joints. Recovery determines how your body can adapt. Pain is just information, it's not damage, it's just signals. Imaging like MRI scans need to be interpreted, but they're not the be-all and end-all. And surgery is a really valuable tool, but it's not a shortcut or a quick fix, and it's not always necessary. So your knee and you are not fragile, they're totally adaptable. And when you understand its biology and respect its limits, your knees and your hips can serve you well for decades. If I helped you understand your knees better, please consider subscribing to the channel so I can keep making more videos, because I'm really starting to enjoy it. And please do comment in the section to tell me about your knee pain or your knee injury. I read all of them and I really enjoy answering them. See you next time.